Okay, so we're going to start our next session. So Taylor Elliott is our clinical social worker, and she's going to give a presentation on mental health issues associated with sickle cell disease. Taylor?
Good morning. Y'all didn't have to answer, it's fine. All right, so like Shirley said, I'm the clinical social worker for sickle cell, adult sickle cell. So I know when people think of social worker, they primarily think of case management, transportation, so social services, disability. Sometimes patients even think CPS. No, I don't do all of those things. I do help with some backup case management for the patient navigators, but primarily I do counseling and therapy for sickle cell patients. So launching right into it. Didn't we already do? Okay. All right, so this is the agenda for my presentation. So you know who I am, what I do. Did a little bit of that already. Community needs. So my experience is working with the community and witnessing what their needs are, and then also what the patients have told me what their needs are. Then we go into mood disorders, kind of the close cousins of depression and anxiety, where they hang out with each other a lot. We go into trauma, so painful experiences, whether it's one event or chronic complex events that have happened throughout the lifespan of the patients. We talk about substance abuse, really scary, but we talk about the screening and then having the talk with the patient. Then we go into coping skills, kind of surviving versus thriving. So we're all kind of familiar with some patients where sometimes we question the choices and it just seems like they're just trying to make it through life as if everything is a crisis. Then we get a little bit into comorbidity, which is going to actually be weaved throughout the presentation a little bit. And then you get to see all my wonderful references. So starting up, like I said, I do therapeutic and counseling services for the patients. So I follow them inpatient, outpatient, and I do community and home visits as well. So like what was mentioned yesterday, a lot of the times building trust with the patients, you got to come to them. Just because of historical, generational, collective trauma around medical care, and then also just kind of the power dynamics that go into an office, you're meeting with somebody you don't know, and then you're expected to spill all your personal business. It's really intimidating. I also coordinate and facilitate the pediatric patients' transition into adult care. So I'm part of their intake appointments. I do mental health screenings, and then we also do the TIP RFT assessment, which is just to get a baseline for when they come into adult care. So looking at if they know their medical history, if they know their insurance, if they know who they can reach out to for social support, if they have any occupational or educational career goals. And then I also do some program and policy development. All right, so getting into community needs, what do I see? So I spent my second year master's internship working in this clinic, and then I came back in April of last year. And so during those times, what I've noticed is there's a lack of awareness about the impact of trauma and mental health, particularly on the physical body. So a literature is out there that trauma, mental health, stress can cause physical somatic symptoms. So increased muscle tension, stomach cramps, headaches, migraines, nausea, vomiting. And so patients aren't always aware sometimes of how their stress can really play a role in their physical health that can eventually escalate into crises. We also get into the stigma against mental health, discussing feelings, asking for help. So even though the culture is changing a little bit where we're becoming more aware of mental health, that doesn't always mean we're aware of the impact that it has, and then also there is still a lot of shame around discussing it. Discussing feelings, feeling like we need to keep it inside, we need to work it out ourselves, we shouldn't be weak on depending on others or showing vulnerability to people. patients are worried, I will report them to the police or CPS. So this goes into when I present myself as a social worker. There has been a patient where her grandmother wasn't really comfortable with me hanging around her at first because she had experience with children being taken by CPS. And so me, a white woman coming in with a social worker title, she's like, I'll see how you are. And thankfully, she's cool with me. But that is still a barrier that patients have in terms of, you got to come to me and discuss your feelings. What are you going to know about my feelings? And then we still get into the lack of access to mental health services. So sometimes if they're not coming to me and they're further away and they need to get outside referrals, sometimes in rural counties they don't really have anybody. They have the CSB boards, so the community service boards, which serve as the gateway for each district into mental health. But when you have a CSB for 2 districts and that's the only mental health resource, you're not going to get a time slot for maybe 3 months out in advance. And then by then, your whole life could have changed 3 months. So what do the patients tell me? Oh, I need to have this presentation mode. Why did nobody tell me that? I don't know how to do it. Okay. I'm supposed to know technology, but I guess I don't. So, what do the patients say? I said it. So, the patients, nobody cares about us. They think we all want drugs. Something very common when I was starting to introduce myself to patients and asking, what do people think of you? When you meet with somebody, what do you think they are thinking of you as they meet you for the first time? And another one, I want to feel better. I want to be like how I used to be. I hear this a lot with transition patients. They do all right in pediatrics, not a lot of pain day to day, not a lot of crisis. And then suddenly what happens when they come into adult care is either they have their first big crisis and they already had that after they've seen us, or even worse, they have it before they see us and they go to the adult ED and it is a traumatic experience for them. Where in peds, their providers might come down and see them. People still see them as kids. They're a little bit nicer, a little bit kinder. The walls are colorful. You come into adult care, it's loud. There's other adults in there yelling. Staff is more likely to show that they're stressed out, and it just feels really uncomfortable, and they wish they could have gone back to the life that was a little bit more comfortable for them and a little less scary. I just need someone to listen to me. So even now, patients still tell me that sometimes they don't feel listened to, and they still feel as if they are being judged based on the records that they come in with rather than what they're presenting with for the day. I want someone to believe my pain, to believe I am in pain. So this is something we all continue to hear and will probably continue to hear as other providers outside of sickle cell continue to be educated about the impact of sickle cell disease. So the tolerance over time of not necessarily to opioids, but pain tolerance. When you live with pain chronically since you were born, you're going to present differently when you are at a 7, 8, or 9 on the pain scale compared to somebody who is in acute pain for the first time and rates it as an 8. And then lastly, I don't want to hate my life. So this is some of the things patients have said to me in terms of they feel like sickle cell is in the driver's seat, has always been, and will continue to be for the rest of their life. This kind of learned hopelessness, helplessness of this is my life, I hate it, and then sometimes that even leads to us discussing and doing a risk assessment if they are feeling suicidal. So, close cousins, depression and anxiety. Both are mood disorders, and while they're not the same, and they do have some shared symptoms, I think of them more as cousins because they like to hang around each other, but you're not always going to get them together. Over time, though, if somebody has chronic depression or chronic anxiety, sometimes the other one will come and kick around with it too. So, There's a lot of different depressive disorders. We won't necessarily get into all of them, but the most common is major depressive disorder, which is what people think of when they think of depression. So then you get into persistent depressive disorder. Think of like Eeyore, kind of always monotone, just kind of there, lack of motivation, lack of energy. And then, of course, you can get into premenstrual dysphoric disorder and then a whole bunch of others. Anxiety disorder, you have phobias. We have one patient who has a phobia of elevators, which has completely impacted her care. And she needs hip surgery desperately, but because it requires elevators and then being sedated, which she is entirely afraid of, she continues to refuse care. Then, of course, you have social anxiety, panic disorder, generalized anxiety disorder, which is what most people think of when they think of just anxiety, where there's just this constant worrisome, broken record going through your mind of, oh, this is going to happen. Well, if I tried to do this, then this may happen, and then all of a sudden this will happen. So there's shared symptoms, sleep issues, irritability, which sometimes people overlook for depression. Your temper is a little bit shorter because your energy goes into just trying to make it through the day, so you're more likely to be more irritable towards people. Trouble concentrating, unwanted thoughts, and problems with appetite, whether that's overeating or undereating. So regarding the sickle cell population, prolonged distress and the somatic symptoms, which I talked about a little bit earlier, can affect the pain. Muscle tension, muscle pain if the muscles are tight and sore enough from carrying the stress physically in your body, nausea, headaches, poor appetite, poor hydration if you're under eating or under drinking because of your stress, sleep issues. Feelings of worthlessness may also encourage the patient not to care for themselves. Going back to the patients who have told me, I hate my life. And that worthlessness of thinking, if this is my life, then why continue to bother caring for myself if this is how it's going to be? And then we also get into postpartum depression, where it's not uncommon, even outside of the population, for after people give birth, that there is this depression, whether it's from hormones or a combination of you have already had a history of depression or are predisposed to it. So those are things that patients have talked to me about and that I have seen. Then we go into scary trauma. So what is it? Definition, a bunch of words. Whoever you ask, whether profession, they're going to think of it differently. But I like to break it down into kind of acute and chronic. So chronic can also be complex. So acute, we think of a recent event or experience that has caused trauma. So 2 weeks prior, you're still having symptoms of having nightmares about the event, stress spells, panic attacks, flashbacks, heavily avoidant symptoms of not wanting to go into an event or situation like that again, and going out of your way, making your life harder in order to avoid having that experience again. So chronic trauma is a prolonged trauma response to a past event or experience. So could be child sexual abuse, physical abuse, having a really bad car accident, or waking up during surgery years ago and hearing the providers talk about you and not being able to communicate that you are awake, miscarriages. So any event can really be traumatic, because what helps solidify an event as traumatic is the lack of control the person feels during the event, and also if they do not receive any social support after the event. Other types of trauma, individual, so a personal experience or event that has happened to the person specifically. So complex trauma, just an underscore, can be one prolonged experience or multiple traumatic experiences. Generational, so usually cyclical family trauma. So I have a patient who her mother had intimate partner violence, her grandmother had intimate partner violence, and then the patient ended up experiencing intimate partner violence. So in a way, seeing the patterns that have been modeled by your family, and whether consciously or unconsciously thinking that is what love is and that's what love looks like. Collective trauma, so a community or group shared traumatic experience. So also understandably, within the Black community, the medical racism and systematic racism that has taken place and continues to take place, and which accounts for some of the distrust towards providers, where literature has shown that white providers sometimes do not believe Black patients' rates of rating their pain and think they have a higher pain tolerance than white patients. So regarding the sickle cell population, patients with a trauma history are more likely to report higher levels and frequency of pain. And this goes into how trauma can have that physical experience on the body as well as not just the mind. So substance abuse, even scarier. So screening for it and the talk. So what we most commonly run into at VCU is opioid use disorder. Okay. It is a problematic pattern of opioid use leading to significant distress or impairment. Usually 2 of the listed symptoms, which I did not list here because there are so many, within a 12-month period. So it's not just within a month you say, hey, I noticed this patient is misusing, they have an addiction. It has to be chronic, long-term, a stable pattern of them showcasing misuse of medicines.
So what are some of the on your list?
So some of the symptoms would be taking the taking the medications for something other than their pain. So like we prescribe opioids for their sickle cell pain. They start taking medications to cope with anxiety, or overtaking them in terms of whatever reason they may else come up with. Also diverting the medications to get money, sometimes maybe for other substances. We've had that happen with a few patients before. Sometimes it can be putting themselves in harm's way in order to gain access to more of the medications. I don't know if anybody has seen some of those opioid commercials where people deliberately have like ran their car into a brick wall or thrown themselves down the stairs in order to try and get more medications. So a way to kind of summarize addiction, I guess, is using despite adverse circumstances. So there is kind of this understanding that, you know, this is running my life, but the withdrawal and the cravings overpower everything else, and I need to get rid of those because they are the most harmful to me. So how do we diagnose opioid use disorder? So patient meeting with a behavioral health expert, psychologist, psychiatrist, LCSW, etc., and they'll usually be able to do diagnostic screenings and just meet with the patient over time through an interview process to assess the impact of the misuse on the patient's life. So if you find out a patient fits the diagnostic criteria for opioid use disorder, what do you do now? You have the talk with them. So it is important, in my perspective, to discuss the diagnosis with the patient, discuss documented and witnessed symptoms, and assess the patient's interest in seeking help. So sometimes what we encounter is patients who are in denial. And it can feel very frustrating when you present the evidence to them and they say, no, that's not me. And so that's why the most key component is assessing their interest in seeking help. So if the patient is interested in receiving help, then we discuss the withdrawal symptoms they might encounter as we start tapering their opioids or take them off their opioids. We discuss other options for pain management, such as Suboxone. We discuss available inpatient and outpatient treatment centers for substance abuse. And we help the patient build a network of social support, because oftentimes with substance abuse, it's not just the patient, but the community surrounding them that might be encouraging them to do it. And so that is also a key component of removing themselves out of the environment that might be encouraging them to participate in those behaviors. And so up here, just a little graphic of the withdrawal timeline. We talk to patients about it a little bit so that way they can know what to expect. If the patient is not interested in receiving help, which is what at least we in VCU encounter a little bit more often, yeah, a lot, we have to come up with a plan for prescribing the opioids to the patient. In terms of if they're on a high dose, how are we going to start tapering them? I don't know why this is popping up on me. How do I make this go away? I guess I don't. Yeah, I see it on mine. It's like this screen that says can't connect, but maybe. So, encouraging the patient to see a therapist or counselor. So even if they're resistant to getting help for substance abuse, we can still try and figure out as maybe substance abuse is a symptom rather than just the problem and what might be driving that symptom. So utilizing motivational interviewing. So looking at kind of the ambivalent stage, when do they start to really go into acknowledgement, taking action, planning, maintenance, and also talking with the patient to find out what they find beneficial about this behavior. So something I'll talk about a little bit later is, once again, those choices of why do patients make choices that sometimes are not within their best interest. So going into why they might find it beneficial, is it a coping mechanism and they just don't have any other skills in knowing how to cope with the problems at hand? Are they worried about losing friends who also engage in these behaviors? And that is their primary means of having to build that friendship with them, and they're kind of at a loss of, if I lose all these people, what do I have left? Is it a form of income? So patients who are diverting and who are having trouble holding down jobs because of paying crises, is this a source of income for them? And if they have to give up their opioids, then how are they going to pay rent, pay bills, and take care of their children if they have any? So then we get into coping skills, surviving versus thriving. I'm going to take a sip of water. So something I like to use for kind of understanding surviving is fancy clinical term of rational choice theory. So utilizing old coping skills in new environments that end up leading to dysfunction. So a way to think about this is if you've had a patient who, let me think of one. So part of her coping skill for dealing with abuse when she was living at home as a teenager was running away and going and staying with friends and then misusing drugs to cope with the pain she had experienced from her family. What does that look like now? So now she has her own apartment. Sometimes she doesn't show up. Whether she misuses her medications, hard to say, but she's going and still engaging in behaviors that are unsafe as a means of coping with the challenges in life. So back then, running away from home from people who were abusing you is considered a behavior that is rational. You're going to run away from the threat and seek safety elsewhere. Now you have a home that is safe, and yet you are still engaging in the behaviors, and that is what is leading to the dysfunction in your life. So how do we get them to thriving? Well, they have to be self-aware. They have to know that, yes, they are simultaneously a victim of what has happened, but a continued perpetrator of their own dysfunction as they become an adult and gain new resources and new abilities. They're no longer the scared little child, the 7-year-old who had no choice but to deal with what they were dealing through. They now have patient navigators, social workers, providers, their own adult skills that they have learned over time to be able to acknowledge the issue and take action towards change. Cool. So this is where I cannot see because of this window. So what we need to do is we need to replace these old coping skills with new coping skills. So you cannot simply take the opioids away and say, okay, that was your coping skill, but you need to find a new one. How are they going to find a new one? They might not know what another coping skill looks like, and so that will require some hand-holding guidance to be able to show them how to replace that skill. So then we go into assessing protective factors versus risk factors. So protective factors: family, social support, accessible resources, learning and teaching conflict resolution skills. These go into helping patients make changes to learning new coping skills. Risk factors that might prevent them from wanting to change are a continued unresolved trauma history, lack of family social support, community violence, and poor health. And so, with the 5-minute warning, I am on time. With here are my references. Do you have any questions? Oh,
Talk about when you identify someone with opioid use disorder.
yes.
Figuring out as a team how to titrate them off of opioids. So is your policy at VCU that if someone has an opioid use disorder, they don't get any home opioids, or is it depending on the individual?
It depends on the individual. So I believe with one, her dosing was so high that we couldn't just take her off. But there was another one where she came to us with a pretty extensive misuse history. We tried to give her a couple chances in terms of taking hydroxyurea, being compliant with that, instead of throwing that to the wind and just using the ED and opioids. And continued not to be compliant after a few months, and so we did have to just take her off and prescribe her Suboxone. So we tend to look at it like a case-by-case basis. And it also helps to know more about the patient's mental and social health history, so that way we can get a kind of figuring out of, if we intervene medically, how might this impact the patient's other systems? Yes?
So you touched on when African-American patients, oh, yeah, sorry.
Yeah, do you see that? That one too, huh?
Hello? I can speak. All right. So you touched on African-American patients being viewed as, from providers, as being able to tolerate pain better than Caucasian patients. Could you just elaborate on that a little more?
Yeah, so that goes into the underscoring of racism. So there was literature that came out that said racism and systematic history dating back to slavery and even before then is that white providers, unconsciously or consciously, still think that black patients have a higher pain tolerance, and so thus they will use less aggressive pain treatments towards them than white patients. Yeah, so that was not fact of like, oh, they have higher pain tolerance, but that is a driving factor in why sometimes some of these sickle cell patients are undertreated or given less aggressive pain treatments because racism.
Right.
So yeah, there was one patient who has talked about, he lives in Fredericksburg. He doesn't like having to come down to VCU because he's going to school in Fredericksburg too. But he said, when I went to Fredericksburg, they gave me a couple of ibuprofen and said, you should be good. And he was like, I'm already on outpatient opioids. Like, what is 2 ibuprofen going to do for me? Why did I even bother coming here?
Right.
Yeah. Mm-hmm. I'll get Dr. Smith and then I'll get you.
Taylor, in your practice over the last 2 years, will you give us a sense of the most common thing you see and some of the less common things you see? I think everybody's looking for stereotypes, and so rules of thumb to be expected, psychosocial issues.
Yeah. So, because I deal with patients who have more mental health issues, that's who gets referred to me, that's going to be overrepresented in my answer. So out of that caseload, what I see is people having a trauma history and the people around them after the experience has happened, either they were a perpetrator or enabler and saying, be quiet. And so what that does for them long term is they end up not trusting anybody. And so some of these patients, it's taken months for them to even talk to me about some of these things. Some patients, I mean, I've been working with some for over a year, and that's finally when we have gotten to the root of things. Whereas outside of the population, when I worked at private practice, it's very different when people come to you and they're a little bit more ready. They're past the ambivalent stage of, you know, who is this girl? They're more of like, I kind of know who you are. I Googled you, and I'm here to talk about some things. So
is it fair to call that PTSD?
yeah, I would call it undiagnosed PTSD. So in terms of some of the things the patients have just come with, sexual assault history, child sexual abuse, physical abuse within the family. I'm trying to think. Sometimes postpartum depression that ends up lingering and evolving into major depressive disorder. So a lot of, I guess I see, is unresolved mental health issues that, like I said, they just don't know because fatigue, exhaustion, muscle pain are very normalized with having a chronic condition. And so they take that as to just being that's part of having sickle cell is being depressed all the time. And then I think you said some of the more uncommon things I see.
Yeah, weird stuff.
Weird stuff?
We only have so much time.
I would say phobia. The patient I'm thinking of that you know is the only one I've really encountered that has like a true diagnostic phobia to where, yeah, she has debilitating hip pain, but she will still climb up 4 flights of stairs to come to her clinic appointment because she is not getting in that elevator because she believes it will kill her. So yes, we have some other questions. I think in the back, yes. Yes. Ooh, we just started.
I can talk more about that.
Yeah, Dr. Wapato can definitely, he's more of our hard hitter of like, we're taking you off.
When talking about trauma, we talked about all of the things that you named, but do patients ever talk about pain as the trauma? So pain, PTSD.
I would say kind of yes and no. So when they do talk about pain trauma, it comes as that first crisis that just made everything so much more serious. They go through peds. There's a 26-year-old. He went through peds, did well, thought he was going to eventually go to the NFL, was going to play football in college, was doing well, had his first crisis, and that was the traumatic experience in terms of life devolved around him. He had to drop out, can no longer do sports, had to reassess of as his peers move on, he's getting left behind. So the pain itself, not so much really the trauma, but that first experience where it's like, oh, these people were right, I could die from this, is what ends up being the trauma. Yes.
Me? Okay. Hi. Hi. This might be a bit of a basic question, but just going
Oh, it's
more.
okay.
Thank you. Going more on about the extensive history that we all know or don't know about systemic racism and how it kind of infiltrated into the medical system. Very basic. With all of that understanding and the previous traumas that a patient may have had,
Yes.
what are some of the specific ways, if you're at liberty to share, that you're able to build rapport with this population? Because if we're not able to do that,
Yeah.
we're not able to do anything. And so we, I'm a part of a CBO, and we're kind of facing we're facing some issues, and some of it maybe not so much on our behalf, but I want to understand this entirely.
So,
Not so good bags.
so individual-wise, case management, or just sometimes being there at the beginning, at least every time they're inpatient, and just showing them, I'm physically here for you, these are things I can do, can be the best rapport building. So like they have really strong rapport and relationships with the navigators. But then also too, for me specifically, is just physically being there, and then also just kind of throwing in questions every now and again, not playing 20Q with them, but just saying, hey, do you feel like your pain is being treated adequately here? No, not really. Well, why not? Is there someone or something that's contributing to this? Or tell me a little bit about it. I'm here to listen to you. So once again, if we go back to what those patients are saying are their needs, they want to be listened to. They want to feel like somebody believes them. And so when they encounter a system that does not frequently feel like they're being listened to or believes them, you being the other to that can be a very intimate experience for them. Yeah, you're welcome.
I'd like to address the fact that with mental health in the African American community, there is a stigma.
Oh, yeah.
Especially when it comes to prescribing certain medications for depression,
Zoloft,
anxiety, things of that
Lexapro.
nature. Is share with somebody that you may be in counseling, you're seeing a psychiatrist, or first thing they'll say, "Oh, you crazy," and then you lose a lot of
Miss Taylor, am I going to have to go in the psych bin? Yeah.
So you lose a lot of friends or people that are, like you say, your social network thins.
Mm-hmm.
So how are patients receiving the fact that they may need other medications outside of their pain medications? Are they receptive to that idea that may alter what's going on in their brain or body or whatever?
Yeah, I think the presentation of it helps with that. So personally, with my practice, I don't like to, first, second appointment, be like, let's get you some Zoloft. I like to talk about how we'll work with each other for a couple months, at least, consistently. And if you still notice, I still notice, there's this overall monotone Eeyore affect still going on, then we can start discussing and maybe considering, not jumping into medications. So giving them that opportunity at first to say, medications is not the first go-to, it's best when used in conjunction with talk therapy. So let's try talk therapy first to see if having that outlet you haven't had before helps with the issue, and if it doesn't, then we can go into dual medical treatment. Yeah, and so after that, they tend to be more receptive because they feel like they have more of a choice.
Okay.
Yeah.
Thank you.
I also kind of want to piggyback a little bit on what Taylor's saying. So at the end of this session tomorrow, the last session that we have is going to be on stigma and bias. And it's going to be a very uncomfortable conversation, but we're also then going to have a panel of all of us sitting up here that we want you to ask us questions. Obviously, some of us are Caucasian and some of us are going to be African American. And we feel that maybe there's an opportunity to, whatever we don't address, we could maybe come to a consensus of somehow, based on your feedback, what we may be missing as well. So I think if we could have that collective conversation and piggyback a little bit off of what Taylor's saying, I think it might be helpful to the group too, because sometimes we struggle with that. And we want to make sure that we're doing the right things by patients and making sure that we're addressing all the issues. And so we are well aware, of the barriers in the African American community. We hear about that a lot from our staff. So we do want to make sure that we address that, and hopefully through some feedback, maybe we can come to a compromise of something that might help you on the community side as well as us on the professional side. Thanks, Taylor.
Yeah.
Great. Okay. We're going to try this again. Thank you.
Oh, I removed some of these things. Okay.
Yeah, but they don't stay off. Okay. She keeps coming up. She just keeps coming back. Oh, I know she's here. Okay. Any bag? Oh, just grab her bag. Now that one I know didn't come off because it clicked off before I.
I just texted this to
Kyle? Yay! All right, we're 2 for 3. We're doing good this time. You think so? Kendall? Is Kendall here? Okay. I do, but trust me, they don't stay off. All right, one more. Yeah. I don't, even he can't figure it out, so. Donna? Yay, all right. That's it.
That's it? Who's the next talker? There we go.
So now I would like to reintroduce to you Dr. India Sisler and Taylor Elliott, who are going to talk about the lifespan of transition in sickle cell care.
Good morning. There's Taylor. All right, so Taylor and I are going to talk a little bit about transition. This is a big topic, and again, you guys raise your hands and let us know which areas you have particular interest in as we go.
We should wait until they're done.
Yeah. Everybody gets scanned, and then we can start. All right, everybody scanned in?
No.
No? Oh, we need one scan over here. All right, so Taylor and I are going to talk a little bit about transition today. This is a really big topic. We're going to talk a lot about what we've been doing here, but we're also really interested in hearing success stories or strategies from other places too. So we hope that this will be a dialogue around transition. And just wanted to start by kind of defining, right? So what is transition? And wanted to make very clear the difference between transition and transfer. Okay, so transition is the process where we gradually shift from the parent making decisions for the patient, right? So we have a parent coming in to visit me with me, the parent and I have a discussion, the child's a baby, and we make medical decisions on the patient's behalf. Then we kind of transition into this adolescent parent unit where there should be shared medical decision making among them both. And then onto a young adult independently able to make medical decisions for themselves. So that is transition. Transfer happens when you change providers. So as we've talked about with the lack of adult providers around the country, a lot of pediatricians are starting to see patients well into young adulthood, and there's no actual transfer of care. They stay with that same provider, but that doesn't mean that they don't need to work on transition and helping the family move through this process of the young adult becoming an independent decision maker. So all adolescents require support in making good choices. I think that's an understatement, right? But when it comes to sickle cell, this is even more important because the adolescent and young adult time is really a time where we're worried about increased mortality. in just one generation, like we talked about yesterday, we've gone from having a disease of childhood. So I still see, and Dr. Smith can tell you about it, and Dr. Lopato, they're patients who say, you know, my parents were told I wouldn't live to see 20. I was told that I wouldn't live to see, you know, name an age, which is not the case now. So we're not telling families and patients that anymore. So families and patients expect that they will go through this transition process. There's a shortage of adult sickle cell providers, which impacts our outcomes. And then talking about mortality, this is the data that I kind of alluded to yesterday when we're talking about life expectancy, and you can see that for both males and females over time, it's decreased. And we've seen mortality for kids. So if you look from the 80s till 2005, the mortality for kids has continued to decrease, where mortality for adults has not, and if anything, it's actually increasing. So it makes it even more critically important that during this time where we're starting to see an increase in mortality, a decrease in the number of available providers who really specialize and know a lot about sickle cell disease, that we equip these young adults to make good decisions. This is another way to look at that same data, but gives you the same picture that mortality has increased over time, and it starts to go up right here. This 15 to 24-year-old, that's really our highest risk time. You can see that spike. So this is not a population of patients that we can say, well, when they hit 25 or 30, we'll start to talk about how they need to be an adult. You know, they need to really understand the risk of mortality at that age.
Yeah, it just like keeps going, I guess. Or not.
Or not.
Oh.
Yep. Yep.
Yep. Yep. Bam. Bam.
All right, so same concept. We're looking at kind of the baseline risks of just being an adolescent to start with, and then we're adding on the additional risks of having a chronic illness. So I guess that's to illustrate the 1-2 punch there. Do you want to go through this? Is this your slide? Okay, so lack of access to adult sickle cell care. This is not a new concept to us in these last 2 days, not a new concept overall. So now we understand the need, right? We have this population who's at very high risk, mortality is going up. We understand that there needs to be a transition, so then we have to set our goals. And the American Academy of Pediatrics set forth these goals, which were published, and we use to guide our practice. It is important that there's a youth or young adult centered focus. So I can't decide what patients and parents need for transition. That makes sense to me. I don't know, I haven't lived it. So we need to make sure that it's very patient, parent, and young adult focused. There needs to be an emphasis on self-determination, self-management, and family and or caregiver engagement. No patient transitions on their own. If their family is not engaged, then you're set up for failure. Acknowledgement of individual differences and complexities, recognition of vulnerabilities, a need for a distinct population health approach, need for early and ongoing preparation, including the integration into the adult model of care. So transition doesn't stop at transfer. Just because they move on to the adult model of care doesn't mean that this work doesn't need to be picked up and continued as patients continue to mature. There's importance for shared accountability, effective communication, care coordination between pediatric and adult clinicians, recognition of influences of cultural beliefs and attitudes, as well as socioeconomic status, emphasis on achieving health equity and elimination of disparities, and need for parents and caregivers to support youth and young adults in building knowledge. So this is meant to apply to all children with chronic medical conditions, but I would say that some of these become even more important when talking about patients with sickle cell disease, especially when we're talking about health equity, elimination of disparities, and cultural sensitivities. Another resource that we have found very useful, and those of you from Charlotte are going to be very familiar with the GOT transition. This is used as the kind of backbone of a lot of transition research that's going on around the country, including a pretty large project that originated with Dr. Iffy and Charlotte, and we're a site here too. But this GOT transition is meant, again, for all kids with chronic illness. And if you go onto their website, gottransition.org, there are a ton of resources. It's a really phenomenal site. There are patient handouts, there are all kinds of educational modules, there are information for providers about how to bill for transition services so that you can sustain your program. So there are all kinds of resources. And they've kind of boiled it down to these 6 principles of transition. And it goes right along with the American Academy of Pediatrics recommendations. So you can see that they're kind of lockstep, that you want to come up with a plan, you want to be able to track and monitor it, you want to be able to make sure that you're engaging patients and parents in the process, and that there's ongoing care after transfer. So a lot of those same principles have gone into building this GOT transition program. This just kind of gives you some tools to help carry out transition. All right.
Let's see if we can. Oh.
Come on, Daniel.
Hey, Daniel.
I'm sure I didn't was ready to do it. Watch this stuff. Sorry.
Is anybody else in the room using GOT transition while we're waiting? Yeah, so not a ton of folks, but definitely some. So while we're at the break, you guys can talk about which resources on their site you found really helpful. Skip it.
Yeah, maybe.
All right, we'll come back to that at the end. We can make it work. All right, so from the feathered pediatric nest to the adult sickle cell medical shack at VCU. I mean, I feel like that's a little over the top. But sometimes that's what the patients feel, and that's how they describe it. So even though I certainly don't see the adult medical home as a medical shack, any change is hard for people, and so a lot of times that's how they describe it. The goals of our transition program, this is really in line with the American Academy of Pediatrics. We don't need to go through that again. What age should transition start? This is a question we had yesterday, and I said there's a lot of debate, and I don't think there's a really great answer. What we decided to do here was that transition starts at high school entry. So we keep track of a grade level of all of our patients, and we look at the list of patients who are upcoming freshmen, and those guys kind of officially enter our transition program. We make a referral to the clinical social worker on the adult team, kind of ends as senior year. We try to have the senior year patients start to meet some of the adult providers. And then we also have found that sometimes the medical transfer can happen, but the transfer of the psychosocial care can sometimes be a little bit trickier for patients. So if they have a psychologist or a social worker or somebody on the pediatric team that they've become really close with and they feel like they have a great therapeutic relationship with, sometimes what we'll do is transfer medical care and then delay the transfer of psychosocial care so that there's a little bit of overlap and they have a trusted psychosocial person that they can kind of talk to and can help them work through processing the medical transfer. We don't do that for every patient as a rule, because not every patient has a really great established relationship with our team, but for those who do, we offer that to patients and have gotten really great feedback. We used to provide services until age 25. We found that that was not hugely successful, just as feedback. We found that it really fragmented things. We thought, this is a perfect example of like we were well-meaning. We thought we were gonna say, well, if you really love your psychologist, you can stay with them until 25 and we'll have a longer overlap. And what we found was that it really started to fragment care. So our collaboration has really been over the last 10 years. I've been here 10 years, and I think the first time I ever really met with Dr. Smith, the topic was transition. So we've been doing this for about 10 years now, and we've gone through several iterations of our program. What we found was initially when all we did was really start talking about transition, start emphasizing transition, and start providing some education to patients. I'd say our early efforts were not, every patient every time, but just when we started to begin our work, we were able to increase the number of patients who went to their first adult appointment from 50% to 92% over a couple of years of intervention. So it became really clear to us very quickly that this was important work and that there was a lot more to be done. What we found was those 92% of patients who went to the first visit, then there was kind of a trickle off in attendance to the adult clinic. So although that was our first outcome that we measured, we realized there's a lot to be done. So the last couple of years, what we've done on the pediatric side is that we have we do 2 retreats, overnight retreats at Camp Hanover, which is outside of town here. The pediatric team over there and I spend the night in cabins with these kids. We invite all of our high schoolers. I think we have some pictures of this later on. But it is so fun, and we enjoy it, I think, just as much as the kids do. We have all kinds of traditional camp activities, so we do s'mores at the campfire, and we do a low ropes course, and we go canoeing and paddleboarding. But we also sprinkle in some education in a way that doesn't really feel like education. So one of our retreats each year, we kind of focus on the medical teaching. So what kind of sickle cell disease do you have? We do the plate activity with, kind of to know your genes. And then the second retreat, we really focus on more psychosocial, educational planning, vocational planning. For some of the kids, we'll do career assessments and kind of strength assessments to help them start to think about what might be a good long-term educational and vocational plan. We have adult patients come and talk to them about what transition was like. Last time we had some patients a couple of retreats ago who said they were really having a hard time deciding how to talk to their partners about their sickle cell disease. So we had a couple come and talk who've been married for 30 years about their relationship, how it started. The gentleman has sickle cell disease, his wife does not, and kind of talk about what had worked for them and what hadn't. So we try to listen to the patients and understand the challenges that they're having and support those through some of the programming at the retreats. We also, every patient gets a big binder when they enter the transition program, and so every visit there should be some teaching on both a medical component and a psychosocial component. So the medical things I think are pretty straightforward and obvious. Some of the psychosocial things we hit on are insurance. How do you have a medical directive? Once you turn 18, how does that change when you enter the hospital about whether or not the staff will even talk to your parent? And how do they release information? Some of those practical things that patients might not think about. And then I think, what else we have here? Okay, so we were talking about transition outcomes. Again, we had a really great improvement in how patients went to their first adult patient visit, but then a year afterwards, only about 60% of patients were still in care. 2 years out, only 30% of patients were in care. So this is our current team that we're trying to, that is working on the transition process here, and a lot of the work that we've been doing over the last couple of years has really been trying to beef up transition services on the adult side. As they've built their medical home component, how is the adult team going to continue to build? So we have we hand off care at a meeting once a year. The adult and pediatric teams get together and we run through the list of seniors who are going to be transferred. We talk through what are some of the medical challenges we've had with these patients, what are some of the psychosocial challenges we've had with these patients. We kind of go through lessons learned. So we really try to make sure that we have that verbal handoff. We're really fortunate here that we're both in the same medical records, so we both, they can access all of our records from previous encounters, so that's very helpful as well. On the adult side, I'll let Taylor talk a little bit about the process that they've built for our transitioning patients.
So we get into it a little bit more specifically later, but still kind of going on with the synopsis overall. Outpatient nurse practitioner Caitlin, who presented nutrition earlier, meets with the pediatrical clinical team to complete like a basic demographic form, so that way we can get the patient's medical and kind of social history transferred over to our records more accurately, rather than just interview by the patient who sometimes their answer is, I don't know. We then start working to get appointments scheduled in the adult clinic and provide patient notification to the pediatric team and also to the patient so that they know when their adult appointment is coming up, and then also some things to expect at their adult appointment. The patient navigator, so each patient is assigned a navigator who reaches out to the transition patient during the initial process, just kind of introducing themselves, saying this is the services I provide. We'll be able to meet in person at your first appointment, so you can start putting a face to a name. And then also at that first appointment is when they meet with me before the provider, so I can do the TIP RFT assessment and then the mental health assessments as well. So as Dr. Sisler was mentioning earlier, so the retreats per year, they do a fall retreat and a spring retreat. There's some kids having fun. And so, like she said, they do games, activities, so the s'mores, role-playing, and then also kind of a Jeopardy board in terms of making it a little bit more fun to quiz them about their care rather than sitting across from them in a sterile hospital room saying, do you know what your genotype is?
So this role-playing activity that we did, we gave the kids all kinds of props that they could use, and then we let them choose medical scenarios. So this particular patient with the mask on is the patient in that scenario who's at an emergency room visit. And so he picked that mask, which I thought was so telling. And then the other patient is playing the mother. Okay? And what we learned through this role playing, with which I would never have picked up on in a million years in our clinical encounters, was that his mother drove him insane when he was in pain. And the way that she spoke to the providers and spoke over him and answered the questions, and she thought she was advocating for him, it drove him nuts. And it opened up this whole conversation with us of like, why'd you play the mother that way? Why'd you do that? And then it enabled us to have a conversation with he and his mother in a very sensitive way, so that we were, mindful of her feelings too. But it was really interesting how we learned a lot about how they perceive the medical staff. We learned a lot about how they interact with the other people in their family during these medical encounters. I thought that was one of the most telling exercises that we've ever done. It was really awesome. The other thing we always try to do is an activity where we give back. So down on the bottom there, these are candy bouquets that the kids made for folks in a nursing home. So every time we try to do one activity where we give back, and we try to really capitalize on the how does it make you feel to give to others? How does it try to have an activity where we're taking patients out of, we don't want to focus too much on their own pain and suffering, and sometimes it's helpful to be able to figure out how to take that focus outside of yourself. Sometimes that's a good coping mechanism, and so we talk a lot about that through activities of giving back to others.
Yeah, so I can come back over. So transition services, so like Dr. Sisler was mentioning earlier, they start talking about it earlier. but then really start putting the pedal to the metal like 17, 18 years old of like, this is happening within the next year, so let's get a little bit more serious. And then we focus on those transition services in our clinic until they're 25-ish. So some of those things, young adult support group, the high school seniors are invited to that as well, so they can start to see what their peers are like in the adult side of clinic and what experiences they have firsthand. Once again, a little repetitive, unfortunately, but patient navigator, social worker, meeting with them for that intake appointments. And like Dr. Sisler mentioned earlier, they continue to have access to the appropriate psychosocial services if they are really benefiting from that, and it might impact their care and transition to adults if they were to end the therapeutic relationship too early. So, preparing for patient to adult care. So this year we're trying to do a new transition process to implement for incoming adult sickle cell patients. And so I think we've had really like our first class of a little bit trial and error in trying to achieve this. So the target was patients 17 to 18 years old who are graduating, and the new process kind of consists of 4 phases. So taking off from pediatric care, limbo that time in between peds and adult appointment, landing in their adult appointment, and then starting to settle into adult care. So getting into a little bit more specifically, taking off. So they are leaving pediatric sickle cell care, coming into adult care, and they know this, hopefully. And so the social worker, so me, and the outpatient nurse practitioner, Caitlin, tried to meet with the patient during their last pediatric clinic appointment as more of a little less formal, little less stiff of saying, hey, we're coming by, so you can start to put faces to a name when you see us in the adult side. Hopefully it makes it a little less intimidating because you already know some of the people you're going to be meeting with over here. So yeah, the purpose is starting to build that initial rapport with the patient and their family. If the patient and family is open to it, just kind of having a conversation about maybe their medical information, some of the needs they have right now, worries and concerns they have about adult care, and answering any of those questions. And so the important notes, as Dr. Sisler has been mentioning throughout, is still including the family, the parents, the guardians in the patient's care at this point. Because while they are transitioning from being the primary choice makers, we're trying to switch them to collaborating with the patient, the adolescent, and then also transitioning to like kind of a safety net of your kid's trying to be a little bit more independent. You can still be there for them because it's scary for you and scary for them, but let them take the reins a little bit and see what they have to do, because this is going to be the rest of their life in the adult care. You're not going to be there with them all the time, and you can be there with them now through this process to help make sure that they have the skills to continue taking care of themselves. Then we go into limbo. So they already had their last peds appointment. They're done with that. They know, okay, next time I go to the hospital, it is for my adult clinic appointment. So the process for this is that the assigned navigator / community health worker and social worker will reach out to the patient, scheduling the first clinic appointment, discussing the plan to meet with the patient before their clinic appointments, and helping to orient the patient to the adult program. So kind of talking about the medical home, what services we have to offer for adult patients that might be different from the peds resources they have over there, how to access those resources, understanding that their patient navigator, the social worker, who else can be their go-to if something arises as a problem. And so it's during this period that some of our patients unfortunately end up visiting the ED in between their last peds appointment and first adult appointment, and that serves, as previously talked about, the traumatic experience of introducing themselves to adult care. It serves as kind of a rude awakening, patients have described it. Some patients say, after that, I did not want to go. I wanted to skip my adult appointment, and then I did. And so a lot of patients end up getting traumatized by that experience of you go to the ED, it's not your providers visiting you, it's a whole new set of attendings that change every week. Nurses change every couple of days, every few days. So who might be caring for you the day before is not who's going to be caring for you today. Then we go into landing, where they hopefully arrived for their first clinic appointment. Sometimes transportation does get in the way because parking at VCU on the adult side is not as easy as peds, where they have the parking garage right underneath the hospital. And then also the adult hospital is built a little bit like a maze. You go through Gateway, and then you go through Main, and then you go through Nelson, and then you go through ACC to get to your clinic appointment. So this is where it is the big formal introduction. They meet with their patient navigator. They meet with me for the mental health assessments, and then they get to meet one of the sickle cell providers for adult care. Usually it's going to be Caitlin, which is why Caitlin comes, our outpatient MP, to their last peds appointment. So more specifically, once again, the navigators are introducing themselves in person. Really trying to get that face to a name to make it a little less scary rather than people calling you over the phone saying, hey, you have to be here at this time, see you there, bye. Discussing the adult program, reviewing the transition policy, then they meet with me for the assessments, and then they start meeting with the medical provider to build that kind of provider-patient relationship and starting to work on how to establish their care with us. During this time period, patients sometimes drop off, so we encourage, like the adult team, reach out multiple times. Because as previously discussed, sometimes the patients will have their first real crisis. Not that any previous crisis isn't real, but I guess a more serious one that lands them inpatient for a long time. And sometimes if they haven't had that yet, they kind of brush off adult care. They've gone through peds with minimal crisis, minimal day-to-day pain. They think they can handle it. But as we know, sickle cell is a progressive disease, and unfortunately, if we want to use slang of sickle cell puberty, you kind of have that bad crisis in your late teens, early 20s, and that's when you're like, this is serious. Then we go into last phase, settling. So they attend their second clinic appointment with us. So once again, they have one more appointment with me in terms of finishing up any assessments that we were not able to do during their first initial appointment. And then they meet with their medical provider to continue learning about adult care, what are some responsibilities they may have, and what are some available treatments, such as bone marrow transplant, although I think they're starting to work that over into peds too, right? Mm-hmm. Yes. So, important notes during this time, working hard to establish a proactive routine with the patient and their care. So something Transparency VCU is that oftentimes it's very easy for these patients to come to us in crisis, and then we meet them at that crisis, and then we continue to work through every crisis retroactively. So the problem comes up first rather than us trying to prevent the problem from happening. And so this transition process is a way of trying to be more proactive in assessing what needs they may be coming in with, and then starting to triage their care in terms of, okay, this patient for the past 2 appointments has mentioned consistently needing case management needs. That lets the navigators know they have to be involved in this patient. Or they need mental health services where they have a history of depression or they had a previous suicide attempt. So that lets me know this patient needs to be seen consistently and be involved in their care. Or maybe they need empty nest care where they're doing fine, they're doing all right. And so they just might need a check-in every 3 to 6 months. So instead of hand-holding, following up with them weekly or multiple times a week, checking in on them every so often and be like, hey, you doing all right? If not, I'm here to help you, I'm here to be there for you. So, additional interventions. Like previously discussed, we have a transition support group. We try to do it monthly. It's a little bit hard because turnout isn't always as expected. But this is for patients who are transitioning or have already transitioned into adult care. So graduating pediatric patients are invited, adult patients ages 18 to 25-ish are invited. And so the purpose of the group is really educational opportunities in terms of whether it's disease-specific or not disease-specific. Topics of interest that the patients have voiced that they want to talk about, whether it be mental health issues or identity outside of being a patient. And then also, in my perspective, the biggest component is having a social event where they are not seen as the patient being their primary identity. They are the human first, and the patient is only a portion of what makes them who they are. And they get to be around peers in just a normal social setting that maybe they have not had before because their parents said, no, you can't do that, you have sickle cell, or maybe they tried to do something, their disease got in the way, just allowing them that space and time to feel normal with other people who understand what they're going through.
I think I just want to echo that for the, talking a little bit about the transition retreats and what I think we've been able to accomplish for patients that's been so important. The first and foremost is networking, because most of these patients beforehand, that's the feedback we get consistently is, I didn't know anybody else with sickle cell before I came on this retreat. And these kids stay in touch. They all Snapchat each other, like they'll be Snapchatting each other from clinic visits. You know, they'll be like, smile, I'm gonna send this to so-and-so, or they visit each other in the hospital. They keep up with each other. We had 2 patients, I always like to tell this story, who came to I think it was our first retreat, and they'd been in school together their whole lives, and neither one knew the other one had sickle cell. They ran in totally different circles. She was super preppy, cheerleader, captain of the cheerleading squad, straight A student. He was not. And they gave us the feedback that, you know, even though I would never have spoken to him in school, like if he's not there, I text him, I make sure he's okay. I make sure he's just skipping and that he's not sick, was what she said. So it gives these kids, they were in high school together for 4 years, and it gave them someone else that they could look for in the halls. So that feedback we really get consistently. And the other feedback we get, and it kind of feeds, I wanted to mention it because it feeds into the rapport building question earlier, is that I think the kids who participate in our retreats really see us as a safe space. We get to know them so much better than we do just in clinic visits. And we've had situations, we had one girl who ended up getting pregnant her sophomore or junior year in high school, and she called Jennifer before she told her mother or anybody else, because Jennifer was her safe space, and she had been able to build that relationship with her over retreats. And some of the things that these teenagers feel comfortable telling us, and we can frame it through the lens of their sickle cell disease, because it might be a little bit different than for patients who aren't dealing with a chronic illness. It's just been really helpful for us. I feel like we provide better care because of the retreats, and patients really change. They give the report that it changes the way they see us.
Yeah, something I wanted to share was that, you know, me being a newer social worker, I've only been here since February, I was having a lot of difficulty being able to connect. But it's hard for me to just connect with our teenagers. So like, who's this random person coming in? And being a social worker, there's certain things that they assume that I'm going to talk to them about or try to figure out. And so building trust, like the rapport building, was like one of my main challenges. And the transition retreat was something that really helped. I think a lot of our patients feel more comfortable with me. Like I had one patient who would literally ask me to leave when I would come into her appointments and say, I don't want you in here, leave. And she would ask me to leave. And so I respected that. But then she came to the retreat and wanted me to be around her like the entire time, and now asks for me every time, like, you know, you come to clinic. So it's a different vibe that they get from us being there and being able to participate with them, just being a human and not just their social worker or their doctor. And so I really did find that helped a lot.
We've never had any kids from other places come to the retreat. I feel like we kind of walk the fine line of risk and liability anyway.
Yeah.
We often will do the like, ask for forgiveness instead of permission approach with some of our retreats, so I don't know how we would be able to incorporate that in. Yeah. Mhm.
Are there support groups for the parents who, their children, they're giving up that role for the children to take care of their health? How do you encourage the parents to relinquish that and allow the children to take that role?
I think it is definitely a missing component of our current transition process. The first iteration of transfer and transition that we did here, we had these sessions during the day. So we would close clinic for the afternoon and have patients and parents come. And we would do breakout sessions for the parents and breakout session for the patients. And the parents did give us feedback that they found that really helpful. The problem was over time, attendance wasn't great at those. So we did these transition retreats as a kind of brainstorming to see if we could get better attendance and buy-in from patients and families. And we really did get better attendance, but we lost that component with the parents. And I think the other mistake that we did was initially the first year we did transition and transfer, we decided that the first adult visit, the patients went back without the parent. They were going to be, you're an adult now. That was a horrible mistake. And we've since learned better, but I think a lot of the work with the parents happens once the patients have already transitioned over. And I'd love to hear other ideas about how we could do a better job of incorporating that in our program.
Hi, we work with the with VCU, and we're the community-based organization, and to kind of help with you guys, what we do is we support what they do. So with this transition, it is new, and since we're helping out with that, we have actually started creating educational workshops for the parents, and that's to come as well for 2020, as well as the transition for the kids as well. So that's where the CBOs come in at, to support the hospital and to support the team, the social workers and everything else. And then when we have events, they actually come out to our events as well. So they see that face and they're familiar with that, but they also participate in that transition, and the community participates in that transition as well.
Yeah, so we always have our CBO partners at our retreats, or we try to, because we want patients as they become young adults to understand what their community resources are and who they can call for certain things. So we want them to get to know our CBO partners in a really informal setting where they can see them as really allies that they can reach out to moving forward.
Just a quick question. What made you all decide to start the transfer of care at 18? I know I can say on behalf of CHOP, we transfer care at 22. Mm-hmm. We start the transitioning process at 14, the conversation, allowing the patient to be in the room by themselves with the medical team, asking the parent to, like around 16, to step out, or we'll do some other stuff with the parent while the medical team is with the patient. But we've always thought like 18 is like too young, like they're still babies.
I think it is too, but I'll tell you that
legally they're adults, but it's
I
like,
know. So the driving force actually when we started transition is that we don't have I don't know if you guys have seen the construction over here, but we're building a freestanding inpatient children's tower. So our current inpatient space is like a hospital within a hospital. We have one floor on the 7th floor of the main hospital where pediatric inpatient, and we never have enough beds. So consistently we get pushback from the hospital for patients who are 19, 20, 21 to be hospitalized in other parts of the hospital, and then it becomes a safety issue because you're trying to take care of patients in lots of different locations. And so the inpatient care kind of limited us, and that's why we decided to start. And we chose high school graduation as a marker. So sometimes patients are 19, sometimes they're 20. And every time they get admitted to the hospital, I have to, the nurse manager calls me and says, can I move this patient? And I say no. And then we have the same conversation every single day over and over again. So we do that for patients when we have to. But the infrastructure here is not designed to support continued care of those patients on the pediatric side. Once this is construction is done, I think we have the opportunity to revisit that discussion. Yeah.
That's cool. Thank you.
My question was, okay, my question was in regards to the retreat, the role play, and the mother driving the child insane every time that child had a pain crisis. From a parent's perspective, you just don't know what that child is experiencing, and you don't know what to do and how to help that child. The fear and the terror of dealing with that child in that bed and knowing, being a black African-American mother of children with sickle cell, and knowing how the racism is when it comes to dealing with our community, you're dealing with so many issues, and you want to be assured that they have your child's best interests at heart. So parents need some type of mental stimulation to help them relax with whatever it is that their child is dealing with, especially new territories such as med ports, gallbladder surgeries, acute care syndrome. Parents need, you get them to explain what they're going through, but you need some type of counseling. And, I mean, because we will treat the medical staff a certain way, because we have that person in that bed's best interest at heart. And we don't know that you absolutely do. So we need to address that component early on with parents.
There's a lot. His particular complaint was that she went from 0 to 100 no matter what the situation was, and if she felt like he was already getting good care, maybe just stop at 50 until she reserve 100 for like when you really felt like you need to advocate. But I think you're right. I think you're exactly right. We have one program, I don't know if you can speak to the Coffee and Conversations. It's gone through a couple of different, we have a program for, because a lot of this stress I feel like we see when patients are hospitalized and the parents are like climbing the walls trying to figure out what in the world to do. So we have one acute intervention where we invite parents to come out of the room and meet with other parents and have an opportunity to, with our psychosocial staff, to kind of work through some of the acute issues of being in the hospital. But I think there needs to be a more ongoing.
Yeah, because like the children say, they have met any other children with, it's rare that you meet any other parents that's dealing with it. If you're not connected with a community-based organization, something is rare. And then what type of mentoring programs do you have for like the children that have transitioned onto the adult program to come in and maybe mentor, volunteer, or do workshops with the younger children to kind of prepare them for not just the medical staff, I mean, like the interactions with people.
So that's a great question. The whole premise of the study that we're participating in, that Dr. Iffy and Charlotte has put together, is looking at peer mentoring in transition. And how can we do that in a way that's helpful? Is it helpful? So that study is enrolling young adults to serve as peer mentors. And then we're also enrolling advisors who help teach people how to mentor, because it's not a skill that everybody has. So it's kind of building this infrastructure, and we're really excited to see what the outcomes are there, to see how we can incorporate that into standard care.
So I don't think that there's necessarily a perfect age for transition, but I do think that there's less than perfect ages for transition. And I'm curious about what is the theory behind doing it at 18, graduation, everything that could be up in an uproar in that young adult's life is currently in an uproar. They are literally going from someone else's child to their own adult, and the society that tells them that they're now an adult, and the responsibilities and career goals and all of these things, and then we add transition on top of it at that point. Where did we get this idea that that's the great time to do it?
Yeah, I hear you. We found that it was a time where we were transitioning a lot of patients to other centers anyway. If they were going to college, if they had other postgraduate care, we had a chunk of patients that we were already transitioning during that summer. So it was already kind of a part of our process then. And we also were trying to look for something that was more of a functional marker, like how much is this patient able to handle psychosocially, how much are they able to do? And that was the best we could come up with. But as I said, as soon as this tower is built, we talk about it all the time. How do we need to change this so that it's better?
Are you at a separate children's hospital, like a standalone children's hospital? Speak out to me, are you at a children's hospital that's standalone?
Yes.
See, I think it's easier there.
Yes.
We have one more time to refer to a specialist. You know, some of the pediatric folks say, I'm not going to see patients over 18. So then you have disjointed care where pediatric providers are talking to adult providers that aren't their knowledge.
Sure.
There are people that they know. So I would rather Dr. Smith and Dr. Lopato, you know, talk to their colleagues that are pulmonary to deal with this patient's complications. So I think, you know, where we are right now, when patients come to the ER, they get admitted, or they have to see other specialists, the safety of the patient comes into play when I'm thinking about to care for them. And so that's why I feel that it is more comfortable, it is a transition point, it is a functional transition point. And yeah, everything's changing, but, you know, if we can kind of help prepare them, you know, and try to help transition and have some of the backbone of the social work, the CBOs that are that continuity, it's got to go at some point. Let me tell you, we got some that are 21, they still don't want to go, you know? So at some point you just have to have an expectation of that.
We also
So
found.
we work with child development specialists to really be able to recognize the developmental stages that young adults are in, and how do we use that in a complementary way to enhance transition programs?
Right.
I think that's from at least for us, we have a huge psychosocial team that tries to stay involved with every patient from the ground moving forward, especially at the transition age, because that is so important. And we know that there are some kids that get to 18 and they are ready to go. And there are other kids that get to 26 and they're still not ready to go. So
Yeah.
I think that's at least from our.
Yeah, and just to say, we do have an ongoing kind of assessment that we're doing to look at transition readiness, and we keep patients well past graduation if we agree with the adult team that it's the right thing to do for that particular patient. So we will buck the system when we need to because we feel like it's the right thing to do for a patient, but as Jennifer points out, it's mostly a safety issue that the transition kind of happens when it does.
This is more so just a comment, just because transitioning is something that I know we're very passionate about down in Philadelphia, and something that we care about a lot. And sounds like you said it's a logistical problem right now when it comes to just being 18 versus however old. So that's understandable. There are a lot of, this conversation is so great and has sparked so many thoughts, so bear with me. I'm just gonna kind of go rapid fire right now. I think that you made a great point by talking about, parent support. I come from a mama bear who, was very overbearing, just loved me very fiercely, and was so involved throughout my care, and probably not even probably, is the reason that I am here today at 30 years old. But, there was that point where it's just like, oh, I'm ready to take care of my own health, and I don't necessarily need you knowing when my doctor's appointments are. I'm at a point, she doesn't even know who my doctor's name is. She doesn't know when my appointments are. She knows, I'll check in, my hemoglobin was yada yada. Kyle, you should go back and, make sure you follow up on that. But watching her go through that process is kind of like a loss, where she's trying to figure out, what her role is in life. This is something she's poured her entire life into, and, into me. And so that put me into a position of how am I going to make her feel more included? And it has to be outside of sickle cell, because sickle cell is a part of my life, but it's not my life, So I had to try to figure out how was that relationship going to still be sustained, and for our relationship to move forward. So I think that is a huge, huge aspect of, not forgetting the people, the caregivers who are a part of our journey. When it comes to patients, I think that it is important for us to really empower our patients and throughout their transitioning, healthcare providers, caregivers, and even peers as well. everybody is different developmentally, like we said. Some are already at 18, some are already at 26, whatever. But we also have to be aware that, there are things that are going on within our bodies when it comes to like these silent strokes, when it comes to, like different physical limitations. We have to be aware of that this is such an individualistic disease and not everyone is going to look the same. So I just think that this is a wonderful conversation. Transitioning is the most critical, I feel is the most critical point in a sickle cell patient's life. Well, I don't think I feel that way anymore because we're going to bat for adults now. But, I've lost many friends throughout their transition period. And we need to keep a vigilant eye when it comes to this point in our patients' lives. So.
Awesome. And that's where the focus needs to be with transition is you have to remember that. And that drives the passion for this work, I think, that we all do. Are we out of time? Okay.
But the conversation can